For seizure disorders, there are two here. This is the description. So it's characterized by abnormal motor, sensory, autonomic, or psychic activity. Since there are different types of seizures, the manifestations depends on which type of seizure it is. Table 61-4, I really don't have any questions on this table, so we'll skip that. Let's focus on seizures. Now, if the patient's seizure has an identifiable cause, which is listed in this chart. Now, these are the different types of seizures. All right, so here are the causes. If the patient's seizure is attributable to any of these, let's say allergies, you have a brain tumor which increases intracranial pressure, therefore causes or triggers seizures. You have, say you had a stroke and same thing, you had increased intracranial pressure, you have meningitis, for instance, or any other brain infection. You have drug or alcohol withdrawal, which triggers seizures, or fever, for instance. I had several seizures on my first year of life, so all caused by a fever. You can also have seizures, again, head injury causes increased ICP, hypertension, severe hypertension also causes increased ICP, triggers a seizure, or hypoxemia, or let's say metabolic and toxic conditions. You have, let's say, severe uremia, meaning you're missing dialysis, you have really sky-high toxins in your blood, or ammonia, for instance, that will cause seizures, okay? Indicating brain injury. If there's a cause, then that's what we'll call it. You had a seizure. If there's no identifiable cause, we did testing, CAT scans, MRI, we looked at your blood, there's no reason that we can find that caused your seizure. If that's the case, then you will be diagnosed with epilepsy. You see the difference? Okay. So when do we call a seizure disorder again? If there's a cause, we can attribute the seizure to a specific cause as a seizure disorder. When do we call it epilepsy? When you have a seizure and you have no identifiable cause. Are we clear? All right. For testing purposes, we will only discuss and test the most common type of seizure, which is the generalized seizure, or also known as the tonic-clonic type of seizure. So let's go to chart 61-4. Okay, right, I missed the chart right here. So of all these, we will only test which one? Okay, the tonic-clonic type. There are many types of seizures. So here it is. So the patient usually has a pre-ictal phase, meaning a pre-seizure phase, which involves certain sensory, motor, or neuro symptoms unique to the patient. Not all patients with pre-ictal or pre-seizure manifestations will have the same aura. We call them auras or pre-ictal symptoms. Some will start smelling weird stuff. Some will start having some visual changes. Or let's say Stella, a girl I went to grade school with, Stella had vocal pre-ictal symptoms. She would go really loud. She'd do that maybe 4 or 5 times, and then we all know what's gonna happen next. Okay, some of us know like how many times, and then next thing we'll hear is a loud thud. Okay, so she'll fall over, and then have a seizure. Right? So that was Stella. So that was her aura. I feel bad for Stella because I don't know what happened to her. And at that time, maybe nobody told us what her condition was. I just knew, when I was in high school, and then I knew, oh, that's what Stella was having. That was a seizure. Nobody told us. The teachers just pretty much ignored her. No, they should, I mean, not really ignore, but let her have the seizure and then put her to the side. So the teachers were trained, but they never explained it to the class. Okay, what we were seeing. So no, I feel bad for Stella. She was a nice chick, but and then she disappeared. I don't know which school she eventually graduated grade school from. I didn't see her anymore. So here's what happens. So the patient will have a tonic phase first. So this is after the preictal manifestations, and then they'll have the tonic phase first, wherein the muscles will become rigid, entire body will become rigid, followed by alternating relaxation and contraction. So they'll have jerking movements following the tonic phase. So the tonic will last a few seconds, and then the tonic phase will last a couple minutes. Here are things that could happen during the whole episode. They could bite or chew their tongue. They could get incontinent of urine and feces. And then the post-ictal phase, the patient usually lies motionless. Okay, we'll look at our responsibilities during and after a seizure shortly. And then the patient, upon regaining consciousness, usually has no recollection of the event. Okay? They just know, especially if they have epilepsy, based on their experience, that they have no recollection of the whole event, but they'll see injuries. Let's say they wake up or they're on the floor, or let's say they see unexplained injuries, and then they'll realize, oh, I must have had seizure again. All right. Diagnostic tests. So you saw the list earlier. So we'll run all sorts of tests to see if it's an allergy, if it's a metabolic problem, if you have a tumor, etc. Just to get a diagnosis. Okay. So once we see the potential cause, then can we treat some of them? Let's say here, can we treat a brain tumor, an infection? Yes. Okay, so we treat therefore the underlying cause, and then therefore hopefully we can get rid of the seizure, correct? However, if there's no identifiable cause, then what do we do for the patient? We did all the tests, we can't find the reason. We'll have to keep them on anti-seizure medications for life. All right? Okay, we'll discuss that because epilepsy is discussed separately. Now, to check whether the patient experienced a seizure, this is of course after the fact, we need to do an EEG. You've probably seen them in some of your patients during clinical. Have you ever seen a patient being wheeled out while they have almost like 3 dozen wires attached to the head? Have you noticed patients like that? Okay, so that's an EEG test. It can be done at the bedside. So they'll attach dozens of electrodes connected to a machine and then measure the electrical activity of the brain. If there's increased electrical activity, then that's positive test. Patient had a seizure recently. It's usually ordered within 24 hours of the suspected seizure. All right, here's our responsibilities now. So what do we do for the patient having a seizure? So these are your responsibilities during the seizure. Again, this aura here is totally unique to the patient. You can't say, oh, all patients smell smoke. Okay, no, it's unique to each patient experiencing the seizure. So these are all that you'll note. Okay, what movements, what happened to the patient during the seizure, what did you observe, whether or not there was incontinence. Very important is the duration of the seizure. I'll explain later when we get to the life-threatening complication of the seizure. Let's say the patient's seizure lasted less than 5 minutes. Very good. Now, what do we do? The seizure's over. So how do we help the patient? Remember, the patient's unconscious, so therefore, can they protect their airway? No, they'll be unresponsive for who knows how long. So they'll be out for at least 30 minutes or longer, depending on how long the seizure lasted. So put them in what position? Okay, aspiration precaution, side lying. We maintain seizure precautions, meaning after one seizure, could they have another one? Okay, so let's say the patient is known to have a seizure, or we anticipate that they could have a seizure, such as, let's say the patient has really low sodium. Okay, so severe hyponatremia, patients at risk for seizures. Let's say after a stroke, after a head injury, or the patient is in severe metabolic acidosis, for instance, or a patient has a tumor. So these patients are at risk for a seizure, so the doctor will institute seizure precautions. So what 5 things will you prepare? Oxygen, suction, what else? Bed is low. Bed rails are padded, side rails are padded, and what's the number 5? No, we did that already. Oxygen, suction, IV access. Okay, so that's number 5. What are they again? Select all that apply. Oxygen, suction, IV access, pad side rails, and bed lowest position. Okay, so those are your seizure precaution preparations. All right, so that's all here. All right, so now the medications are under here because it doesn't make sense discussing it under seizures, the seizure section, because it's the same medication. So in epilepsy, what is this again? When do you get a diagnosis of epilepsy? Okay. 2 or more seizures with no known cause. Okay. So here's a chart summarizing the care we saw in the paragraphs earlier. I won't repeat it. Just a few things because this was not mentioned in the paragraph earlier. So how do you protect the patient from injury? They're having a seizure right now. Because it says do not restrain the patient movement. So you just watch. Okay? You just pop popcorn and then let's wait until this is over. Okay. Oh, look at that. Yeah. Do we do that? Okay, keep the patient safe. So this around here, for instance, okay, make sure it's clear of any objects that could cause injury. If she's by the train platform, let's say it's in 23rd Street, okay, she's having a seizure right there, close to the red yellow strip. Just make sure there's no train. There's no train. Just let her be. No. Okay, of course you don't want her falling into the tracks, right? Okay, so use common sense. Just keep the patient safe. Or let's say there's a knife right there or a shotgun next to her. I don't know who put that knife or that shotgun right there, a loaded shotgun. What do we do? Okay, you know what I'm saying. Okay, so keep the patient safe. Okay, do not attempt to pry open the jaws. So that's why we stop putting padded tongue blades into the mouth. During my time, when I went to school, our textbook still had them. A textbook still said, put a padded tongue blade into the mouth. Okay, obviously, we don't do that anymore. This is the reason. Okay, broken teeth, injury to the lips have occurred because of that practice, so we stopped doing that. Do not restrain. We mentioned that. Put the head to the side as much as possible so they don't aspirate anything, either blood or secretions. Then here again, after the seizure. All right, so put them in aspiration precaution position. Okay, management. There are surgical options, but they don't really work. It works for maybe a few very rarely, but the successful management of seizures, especially epilepsy, is pharmacologic therapy. So we keep them on medications for life. These are the medications. All right, right here. The ones so like I said, disregard the surgical management. Not all people will choose surgery. So the mainstay of treatment is pharmacologic therapy. Table 61-5. Everything that I highlighted in yellow are gonna be on the test. It's most of them because these are all that you'll see in clinical, and therefore they will appear on the entrance. You following so far? I mean, are you highlighting? Carbamazepine, clonazepam. So how is this tested? So I'll give you the drug that the patient is on, and the question will be on nursing responsibilities. Let's say, what will you teach the patient? Teaching will be on the side effects. All right. So those are the first two. Next is gabapentin. Next, levetiracetam. Probably more familiar with the brand name. Forget that. NCLEX will only use generic. Phenobarbital, phenytoin. Okay, these are the most common, all right? The others you also see, but they're not very commonly prescribed. I'd like to include primidone, but that's fine. That's it. So pyramid, valproate. Because primidone, misolene is actually, I should include this. Because misolene is quite common. I mean, primidone, generic. Okay, so what's the success? How do we ensure that the therapy for epilepsy is successful? Well, not all of these drugs will require levels to be therapeutic. Compliance, okay? So compliance with the therapy. Most people will think that they're, after having 1 or 2 years of seizure-free period, that they think, oh, I don't need to take the seizure medications anymore. And then they get a seizure, all right? So they must understand that the therapy, the reason why they're not having any seizures is because the medications are working. Okay, so the medications are preventing the seizures from occurring. Okay, so it's important that they understand that. Now let's go to the nurses part. So since you're teaching the patient to never stop these, what will happen if the patient is on and has an NPO order? What if the drug doesn't have an IV form? The only ones that have IV form, let me enumerate the ones that have an IV form. Levetiracetam, phenytoin. Those have IV forms. The rest do not. So what do we do? Okay, make sure the doctor knows, because we cannot stop these. Doctor understands that, and either they'll say that they'll give you an order to, okay, give the drug with small sips of water, or give you an IV form if available. All right, but what's your nursing responsibility?
Make sure they get the medication.
We cannot, correct, we cannot stop these for whatever reason. Okay, there's no exception. Patient's NPO, that's not a reason. Are we clear?
Yes.
Say again? Who doesn't want to? Oh, of course, nothing we can do there. Patient's the boss. And they have to live with what will happen, okay?
And then they had to
For
take the
stopping,
thing,
right.
medicine.
Yeah, because can they die from a seizure?
Yes.
Yeah, yes, they can die
Toxins.
in a couple ways. All right, so let's go to, these are your summary again of your intervention. So prevent injury, we know the steps, okay? We know our responsibilities. Coping, all right. As far as driving, that's specific to every state. So I doubt if NCLEX will ask you whether or not they can drive because that's state specific. Okay. Some states still give them driver licenses, but some do not. So I don't know how to answer that. Most Republican states are very liberal. Isn't that ironic? So most Republican states are very liberal with giving driver licenses. I mean, they'll give a 90-year-old, a 100-year-old, especially if they're veterans, like driver licenses, okay? Even if they can't see. They fail the vision test. Here you go, sir. Okay. So same thing with the people with epilepsy. Okay, it's really the democratic states that are more strict with with safety as far as medical conditions go. So teaching are again specific. However, most of them, especially phenytoin, since phenytoin and levetiracetam are the two most commonly prescribed drugs, and phenytoin causes gingival hyperplasia, meaning the gums enlarge and get inflamed. So oral care is very important. The patients are taking those drugs specifically. We'll talk about status epilepticus shortly, but this is the consequence. If the patients suddenly stop the anti-epileptic medication therapy, they could go into status epilepticus. We'll discuss that next. So here's your summary for teaching for patients regarding anti-epileptic therapy. Last topic for the day, status epilepticus. So this is a acute medical emergency. So this is going to cause death unless interrupted. What is status epilepticus? This is a condition, two qualifications here that is considered status epilepticus. One is if the patient's seizure lasts 5 minutes or longer, that's status epilepticus. Or if the patient sustains multiple seizures within 30 minutes of each other, meaning let's say at 8 o'clock, they had a seizure. 8:30, they had another one. So the patient's brain have any chance to rest between seizure episodes? Not at all. So that is considered status epilepticus. What are the two conditions again? Seizure lasting 5 minutes or longer, or multiple seizures, 2 or more within 30 minutes apart. It is again an emergency, okay? Medical emergency. So the goal is to stop or terminate the seizure activity as soon as possible. Medical management. There are only 2 drugs approved to stop status epilepticus or to terminate the long-lasting seizure or the repetitive seizures. They are IV diazepam or IV lorazepam. Now, this is why what is included in the seizure precautions? IV access, because can you still start an IV access when the patient is in during the seizure? No, not if you want to get hurt or if you want to hurt the patient. So the IV access should have been established before the patient had a seizure. But we don't know that, so every seizure precaution patient must therefore get an IV access. After the seizure stops, IV diazepam or lorazepam, not both, okay? One or the other. Then the patient will be given a bolus and a continuous infusion of either levetiracetam, or in this particular instance, we can use phosphophenytoin or phenytoin or phenobarbital. Most facilities use either phenytoin or levetiracetam, at least in New York City. Okay, we already know some of these because these are repetitive, like, positioning, suction, and oxygen. Oh, that's it. Any questions?